Alrighty, hello and welcome to the first segment of our NCLEX prep. This is going to be going over the nursing fundamentals topic of the NCLEX exam. A few disclaimers before we go ahead and get started. This is a good overview of content. This summarizes essentially the courses that we've taken that will be on our NCLEX. So the NCLEX has a couple different portions that includes pharmacology, mom-baby, pediatric, psychiatric, nursing fundamentals, leadership, and public health. So this again will be going over the fundamentals. This is a content review, so it's going to kind of break down every section and summarize key points. Again, this is a refresher. It is not totally comprehensive, and this is a good content review that you can watch so that you can go ahead and knock out some practice questions. Practice questions are super important when you're studying for your exam. Try to do between 75 and 100 practice questions per day, and please make sure we review those rationales. That's going to be the most important key to your success. However, we need to understand the content first before we start doing our practice questions. So that's really what this is going to help. So this is kind of what we're going to talk about today, just a little bit of an intro. So let's go ahead and get started. So the first thing we're going to talk about is our acid-base imbalances. It's going to be really important that we know how to identify what imbalance is occurring. So first step, we always look at our pH. Is our pH neutral? Is it acidic or is it basic? We also need to know what our normals are. Big thing is the patient alkalotic or are they acidotic? So when our patient is alkalotic, it means their pH is very high, therefore basic. When we say high, we mean it's greater than 7.45. So it could be 8, it could be 9, it could be 7.8. That is a high pH, so that's going to be alkalotic. When we think the pH is high, I want you to think everything else is high. So the heart rate's going to be high, the respiratory rate's going to be high, the blood pressure is going to be high, all your reflexes are going to be over-exaggerated, all of your sounds will be hyperactive. Also, patient is at risk for seizures. However, there is one low with alkalosis, and that's going to be the potassium. The reason that this happens is acids actually increase potassium. So if we're lacking acid, our potassium is going to be low. Again, kind of on the flip-flop, during acidosis, our pH is low, so it's acidic. It's less than 7.35. Therefore, everything else is going to be low. The signs and symptoms your patient presents with, it's all going to be low. Hypoactive bowel sounds, very lethargic, low respiratory rate. And again, remember, acids will up the potassium, so our patient's potassium will be high. This puts them at risk for cardiac dysrhythmias. In fact, really any issue with potassium, we're going to want to make sure that patient is on a heart monitor. Up next is patient safety. They kind of focus on three main areas: falls, restraints, and seizures. With falls, it's important that we do a full fall risk assessment every shift and make sure that the environment is safe. So we don't want any cords on the floor. We don't want throw rugs on the floor. We want a nice, clear ground. And we also want to make sure that the room is consistent so the patient knows where things are. It's going to reduce the risk of them tripping and falling. We also want to educate the patient on the use of grab bars. When we talk about mobility, we'll also go through things such as crutches, walkers, canes, etc. Restraints are a big topic. Restraints should never be used for convenience or used for medical necessity, meaning the patient is trying to rip out their NG tube, they're trying to rip out their IV, that they are going to potentially harm themselves. So, when a patient is in restraints, you're going to need to document on them and the restraints every 15 minutes. So we're assessing their behavior, we're assessing neurovascular status. They've got restraints in their wrists. We want to make sure that we've got good pulses, good temperature, that they're not too tight. We always are going to try to use other techniques before using restraints, such as de-escalation techniques. Remember, sedatives are a chemical type of restraint, so we want to try everything else before. Seizures, it's important to know how to care for a patient who is actively seizing. If your patient has a history of seizures or any sort of issue that will cause them to have risk for seizures, such as increased ICP, SIADH, things like that, puts patient at risk for seizures. So it's important to understand what is happening with our patients. So we walk in a room, we see that our patient is actively having a seizure. We're going to want to turn them on their side, loosen their clothing. We want to make sure we note when the seizure has started. Remember, seizures lasting longer than 5 minutes is a medical emergency. We never put anything in their mouth. And a big medication we give to patients with seizures is phenytoin. So we really need to make sure we are checking frequent labs. We never, ever, ever put anything in their mouth. And then after the seizure has run its course, we're going to want to check their blood sugar and then give them some oxygen. Up next is our environmental safety. They kind of focus on fires. So what do we do if there's a fire on the floor? First thing we want to do, we follow RACE, the acronym RACE. We're going to want to rescue the patients in immediate danger, meaning if there's a fire in room 303, we're going to get the patient out of that room. If it's in the corner, we get them out of the room. Next thing we're going to want to do is sound the alarm. We want to report where the fire is. We're going to close all the doors on the unit, make sure our patient's doors are closed. We're going to kind of try to contain the fire, and then we're going to extinguish, and we have to use an appropriate fire extinguisher. When using that fire extinguisher, we are going to pull the pin to the extinguisher. We're going to aim the hose at the base of the fire, and then we are going to squeeze the handle. After squeezing the handle, we're going to sweep from left to right. We want to think about environmental safety. We're not going to want to overcrowd outlets. We don't use extension cords. If the cord is old, we're going to throw it away. And if you're ever trying to fit a cord into an outlet and it's just not working, we're not going to try to force it. Okay. Another thing they talk a lot about with cancer chemotherapy is radiation safety. Make sure that patient has a private room and that it's properly marked with a sign, that there is a bin for the radioactive material, there is a set of forceps, you're wearing your proper PPE. Up next, a big key is patient positioning. It's important to know what positions are beneficial for certain procedures or certain pathologies. Semi-Fowlers, this is headed to bed at 30 degrees. Whenever you have a patient on an NG tube, they have to be elevated if they're getting any sort of nutrition, because we don't want them to aspirate. It's also used for patients that have increased ICP. So you can kind of just go down the line. We've got semi-Fowlers, they're up 30 degrees. Fowlers is 45 to 60, and high Fowlers is 90. They're not going to ask you the proper, like, what degree is high Fowlers, but you should know that who would benefit best from being in high Fowlers? Well, if we're putting an NG tube in, we're going to make sure that patient is sitting all the way up. If they're short of breath, we're going to sit them all the way up. Okay, we've got supine. This is laying on your back. I always say you're kind of looking at the sun, you're laying on your back. We've got our prone position when your patient's getting a lumbar puncture, or if they have ARDS, prone does help. Lateral is our recovery position. This is what we're going to put our patient in after they have a seizure. It's very similar to SIMS, except SIMS, they're lying on their left and you are throwing that right leg over. Lithotomy, this is most common for vaginal exams. When we place our patient in Trendelenburg, the head of the bed is lowered and the legs are up. If you're, especially in the mom and baby section of things, if your mom is having a cord that's coming out before the baby, or there's any sort of pressure on the umbilical cord, we put mom in Trendelenburg. Also, if your patient is hypotensive, we're going to trend them down. We're going to try to promote blood flow to the brain. On the opposite, we have reverse Trendelenburg. This is what we use for patients after a cardiac cath. If they went in through the femorals, patient has to keep those extremities straight. And finally, elevate. We elevate the extremity for any sort of injuries, thrombophlebitis, or casts. Ambulation is a big portion of our fundamentals. Really, we focus on safe ambulation. Patient's always going to want to move towards their strong side first. And we follow the strong. We're going to pivot on the strong side. A good rule of thumb, if your patient is unable to follow commands, they're automatically at times to assist. Even if they walk fine at home, if they cannot follow commands, they're going to be times to assist, meaning two people helping them ambulate. When we talk about crutches, we want to make sure that they are properly aligned for the patient. There should be 3 fingers worth of space between kind of like our armpit and the crutches. The elbow should be flexed at 30 degrees. It should not be flexed at 45, should not be flexed at 90, 30 degrees. Crutches can be used for weight bearing and non-weight bearing patients. If your patient is non-weight bearing, we want to advance the crutch and the healthy leg first, and then the bad leg is going to follow. However, if they are able to bear weight on the extremity, we advance the crutches, then the bad leg, then the good leg. When climbing upstairs, I always say our good leg is going to go first. We follow good, crutches, bad. So we're going to advance the good leg, then we advance the crutches, then we advance the bad leg up the stairs. Now, when we're going down the stairs, we flip things the other way. So first thing we're going to do is we're going to place the bad leg down. Then we're going to meet it with the crutches. And then we're going to have our good leg follow. Whenever patients are standing from a chair with crutches, make sure that the good leg is back against the chair, and we always have them use the armrests of the chair. Okay, for canes, we hold the cane on the same side as the patient's strong leg. When we're walking, we advance the cane and the good leg first, and then the bad leg will follow. With walkers, we have the patient advance the walker, then they move the bad leg, then they move the good leg. Keep in mind, walkers are not the safest option for a patient with Parkinson's disease. They have that trademark Parkinson's shuffle, that shuffling gait. It is not really safe for them to use a walker. Up next, we've got some rationales from our basic care and comfort. Kind of ties a little bit of everything in together. A big risk for patients with abdominal surgery is dehiscence, where they can actually split open that incision and kind of the intestines or any other organs can pop out. Therefore, we want to minimize stress. So we don't want them bearing down to poop. That's why we give them some stool softeners, some laxatives. We don't want them vomiting. Again, that increases pressure to the area. So we're going to give antiemetics. We teach them to wear their abdominal binder and splint the incision for coughs and deep breathing by placing a pillow over the incision site and holding it tight. If your patient has had a mastectomy, they must be in high Fowlers, and we will be elevating that extremity. When you're ambulating a blind patient, we have the nurse walk ahead while the patient holds the nurse's elbow. Okay. And when your patients are having insomnia, do not offer them naps. We want to get them on a good sleep schedule. We want sleep hygiene. So we are going to have them stay awake during the day. We are going to make sure the windows are open or the blinds are open. They can see the sun. And really, we don't want them napping during the day. We want to get them back on that circadian rhythm. If you have a patient that is kosher, they do not mix meat and dairy within 3 hours of each other. Jehovah's Witnesses do not accept blood or plasma. They will only get E-alpha and saline, or they can be self-donors. The left side of our brain is our logical side. Think left, logical. The right side of the brain is kind of that wild and crazy side. This is important if there's any trauma to the left side of the brain or the right side of the brain, or stroke to the area. That's kind of how we can pinpoint what side of the brain might be affected. When you're dealing with a patient with hearing loss, we're going to speak normally into the good ear, and we're going to make sure that we are facing them so they know we're talking to them, but you also can write things out if necessary. When we're given hypertonic formulas, which we will discuss in a few slides, this can cause some diarrhea. If that happens, they still need those hypertonic formulas. We can just slow down the infusion rate a little bit. When your patient is hypotensive, this can interfere with the pulse ox reading. So just keep that in mind. If your patient has dysphagia, this is difficulty swallowing. They will need to be evaluated by speech pathology. So you're going to keep that patient NPO, nothing by mouth, and likely they're going to need some thickened liquids. When communicating with your patient with Alzheimer's, make sure we keep it nice and simple and we reduce stimulation. So if you're in the room with that patient, we need to talk to them. We're probably going to turn the TV off. We're going to make sure that the environment is cool and calm. When we're talking about palliative versus hospice care, palliative care can have concurrent treatment, can also be comfort measures, but you're still going to kind of keep going with the treatment. However, if a patient is hospice care, they're going to forego curative treatment. Whenever a patient has acute inflammation, we are going to make sure that we rest. We follow RICE, rest, immobilize, cold, elevate. If you have any sort of acute inflammation, we're not going to touch the area. We are not going to stretch the area. We're not going to try to position it. We're going to keep it rested and keep ice on it. When we're talking about pressure injuries, we can prevent pressure injuries by making sure we turn our patients every 2 hours. We're assessing the skin. We're making sure they're not kind of sitting in urine. They're not wet. We can use barrier cream, but don't ever massage the area. When we talk about safety and infection control, we really tie in public health and fundamentals. First thing we're going to talk about is our standard precautions. These are used for every single patient, regardless of what you have. And then depending on what type of precaution they might have, whether it might be contact, droplet, etc., then we add to it. But no matter what, we're always going to follow our standard precautions. We can always add more, but we must follow these for every patient. We're going to use appropriate hand hygiene before and after entering the room. We are always going to wash our hands if they are visibly soiled. If you're ever going to come into contact with blood and bodily fluids, we must use gown and gloves. You can clean spills with a ratio of 1 bleach to 10 water. And we always keep 3 feet of distance between patients. Even if you do have patients that are in the same room together, 2 beds, there must be 3 feet of distance between them. When we're talking about putting on our PPE, we make sure that we put the gown on first, followed by your mask, goggles, and gloves. When taking it off, we always remove our most soiled pieces first. So we're going to take off our gloves. Our goggles will follow. Then we're going to remove our gown. And then last, we remove our mask and we wash our hands. It's important to know what diseases are reportable, such as tuberculosis, HIV, hepatitis, dysentery, because we will need to report that. When we're talking about preventing illness, we talk about primary prevention, secondary prevention, and tertiary prevention. Primary, this is preventing illness before it occurs. This is going to be making sure patients are up to vaccines. We're educating new moms on car seats, proper nutrition, proper fitness. Secondary, think screening. We want to catch it early if they have it so we can give them the best chance of success. So this is going to be our annual checkups, blood pressure monitoring, pap smears, mammograms, etc. Finally, tertiary, we really want to prevent long-term consequences. This includes rehabilitation. Up next, we have our different type of precautions. So remember, standard, we do it for everyone no matter what, and then we can add to it. So first thing is airborne precautions. These will require the nurse to wear an N95, and whenever the patient is leaving their room, they will need to place a surgical mask on. They need a private room with negative pressure airflow. Examples of patients that will require airborne precautions include varicella, shingles, rubiola, and tuberculosis. Up next, we have droplet precautions. The nurse will need to wear a surgical mask when they're within 3 feet of the patient. They will also need to wear gown and gloves. Patient on droplet precautions can be placed in the same room as a patient who has the same droplet infection. So let's say you have a patient with RSV and you have a patient with rubella. You cannot put them in the same room together. However, Let's say you have a third patient who also has RSV. You can place the two patients with RSV in the same room together. And that goes a little bit more with our leadership course, kind of assigning rooms, making sure who can be paired with who, et cetera, et cetera. But with droplets, let's say you have two flu patients, they can be in the same room together. Okay. Additional droplet precautions include meningococcal and meningitis. When you have a patient on contact precautions, the nurse will need a gown and glove. And when we're disposing of anything that is soiled, we're going to need a non-porous bag. The room will need its own medical equipment, such as a single-use stethoscope, single-use blood pressure cuff, because the infection is spread through physical contact. Examples include lots of our stool, C. diff and hepatitis A. We've got MRSA, rotavirus, dysentery, VRE, salmonellosis. And then finally, we have protective precautions. It's not necessarily that the patient has anything that could infect us, but we might be carrying something that could infect the patient. And these patients have such decreased immunity that the regular things me and you can carry would be very, very detrimental to them. So these are our neutropenic precautions, usually for patients who have AIDS, cancer, patients that have received transplants, or patients that are immunosuppressed, whether it be because of a pathology or because of medications such as steroids and things like that. We're going to utilize standard precautions to keep the patient safe, but we also want to make sure their room is safe. So no freestanding water. So visitors bring flowers that can cause, infection. There might be some bacteria on those flowers and in the water. We also want to make sure they fully cook their food, their meats, their vegetables, their fruits, etc. Also, keep in mind, for nurses who are pregnant, these women should not be taking care of patients who have shingles, rubella, or varicella. Some of our nursing care for safety and infection control, if there's ever an accidental needle stick, first thing we want to do is we want to bleed the wound, rinse and wash the wound. Then we're going to screen the patient for disease. So if you're in room 54 and you accidentally get a needle stick in room 54, they're going to run labs on the patient in room 54. They're also going to start the nurse on ART. If your patient ever has surgical site necrosis, this requires surgical debridement, and we will be placing that patient on contact precautions. Chlorhexidine wash is what is used for MRSA infections. If you do have a patient who has a latex allergy, be careful about food. They could also have allergies to bananas and avocados. If you have an unconscious patient admitted to the ED, we're going to want to remove everything. We're going to remove jewelry, we're going to remove contacts, and we're going to remove any tampons. If your patient has IV lines and PICC lines, we always scrub the hub with alcohol for 10 to 15 seconds. We cannot use those regular purple wipes for C. diff. C. diff must be cleaned with bleach. Remember, C. diff is a contact precaution. Up next, we're going to talk about medication administration. It's very important we always follow the 6 rights of medication. We have the right patient, right drug, right dose, right time, right route, and finally the right documentation. Also important to know our conversions. The most common ones are going to be how to take tablespoons and convert that to mLs. So 1 tablespoon is 15 mLs and 1 teaspoon is 5 mLs. There are 3 teaspoons in 1 tablespoon. Okay. This is just a photo of what a Y site looks like. So if a medication is Y site compatible, it can be ran through the Y site. Our main fluids are going to be our hypotonic, isotonic, and hypertonic. When we think hypotonic fluids, we want to essentially pop the cells. Think hypo, think pop. Hypotonic fluids cause fluids to move into the cells. So if your patient is dehydrated, we're going to want to give them 45 normal saline or 25 normal saline. Isotonic, this is kind of our body's nice match. It's not going to cause any sort of fluid shift. It's going to match the body, but really it's important for fluid volume deficit, okay? There's a difference between dehydration and fluid volume deficit, and it has to do with the electrolyte imbalances. Okay, so if we have a patient that is just simply lacking fluids, whether it be your patient that is hypotensive, your patient in shock, your patient have blood loss, we're going to want to try to match them with some isotonic fluids. It's not going to cause a rapid fluid shift, it's just going to replenish. And by fluid shift, I mean what is going in and out of the cells. Keeps the osmolarity normal. This is going to be your D5 with water, your 9% normal saline, or your lactated ringers. Lactated ringers are usually reserved for patients with burns. And then finally, we have our hypertonic fluids. This is going to pull stuff out of the cell. Okay, it's usually used for hyponatremia and used to decrease ICP. These include D10 with water, D5 with normal saline, D50, 3% normal saline, and our albumin. Just a couple other rationales. If you have a patient that is very small and needs a subcutaneous injection, instead of using a 90-degree angle, we're going to want to use a 45-degree angle. If you're ever giving an IM injection, an intramuscular injection, we use a 1 to 1.5 inch needle. If you ever have a patient that's had a mastectomy, we're never going to give vaccines, needle sticks, IVs on that same arm. If your patient is hypovolemic or has lost sodium, we're going to give 9 normal saline. If your patient has increased intracranial pressure, hypertonic dextrose is the way to go. Again, that's your D10 with water, D5 with normal saline, or D50. Just no hypertonic dextrose. When we're giving intramuscular injections to newborns, we're going to use a 1-inch needle, and we always are going to go the anterior lateral thigh. We're going to avoid the delt, and we're going to avoid the great trochanter. When administering a nasal spray, we always make sure that we point the tip away from the septum, and then you're going to have the patient lean their head forward, and then you inhale and occlude. The Z-track method is used for IM injections. We essentially pull and hold the skin taut. We inject the needle at a 90-degree angle. Then after we fully, push whatever medication is in that, we keep the needle in for 10 seconds. Then we remove the needle, and then we release our hand that was pulling the skin taut. And we're going to apply some pressure. Eardrops, if you have a child less than 3 years old, the pinna goes down and back. However, for adults and children over the age of 3, we pull the pinna up and back. We never touch the ear with the dropper, and we don't want to occlude the ear. For eye drop patients, first thing we're going to do is a little bit of hygiene. And then we're going to remove crust from the eye. We're going to tilt the head back. The dropper should be 1 to 2 centimeters above the eye, and we're going to pull down on the bottom eyelid. Have the patient look up while you administer. Make sure you're not touching the tip of the eyedropper to the eye. When giving an infant a suppository, it's important to either pull their legs up or you can lay them on their left, but the only difference is after we give the suppository, instead of just leaving the patient be, we're going to have to hold their cheeks closed. We also use our pinky. When giving a tuberculosis test, we use a 1 ml syringe and a 1/4 inch needle, and we essentially insert it at a 10-degree angle, and we're watching for a bleb to form. If you're ever giving oral medications to a baby, just place the drop in their cheek. If you're administering a medication through a glass that came in a glass ampule, you will need to use a filter needle. When breaking that ampule, break the neck away from you and don't inject air into the vial. When you have a patient with a nasogastric tube and the patient is receiving medications through it, we have to crush the medications to put them through the tube. Therefore, we cannot use any extended release, slow release, or enteric-coated medications in the nasogastric tube. This is because those meds can't be crushed. And whenever you give a med through an NG tube, you have to crush it. You crush it and you give them one by one with water, and then you flush in between. If you ever have a stat order, you're going to administer the medication immediately, and it's going to be for a one-time dose. If extravasation occurs when you're giving an IV medication, first thing is we discontinue the medication, we stop the infusion, then we're going to elevate and apply pressure. We're going to leave the IV and everything in place. There's two types of equipment that the NCLEX likes to focus on. It's going to be chest tubes and it's going to be ventilators. So for chest tubes, we really want to focus on what are we seeing with this chest tube. There's 3 chambers we need to be aware of. First thing we have is the collection chamber. This is what is hooked up to the patient. This is either going to drain blood, fluids, or air. Okay, when we've got the collection chamber, if we're draining any sort of blood or fluids, we do not want any bubbles, okay? We want it nice and drain in that liquid. We want to keep track every hour how much output they have. If there's drainage over 100 milliliters an hour, we need to call the provider. Up next, we have the water seal. We want tidling. Think like on a lake. We want tidling in the water seal. Intermittent bubbles are okay, but we don't want it to be like a jacuzzi. We don't want continuous bubbling. We've got all that bubbling. There's got to be an air leak because that is so much air that's causing all that bubbling. And finally, we have the suction control. We need continuous bubbling in the suction control because that suction is what's causing that bubbling, and we're hooked up to continuous suction. So therefore we need continuous bubbling. If there's intermittent bubbling, we need to up the suction pressure. Make sure that it is properly hooked up to suction. Got a couple pieces of troubleshooting. If a tube becomes unhooked from the chamber, first thing we're going to want to do is clamp the tube for 15 seconds. Remember, we cannot clamp longer than 15 seconds. So we're going to clamp the tube for 15 seconds. We are going to cut the tube by the patient. So if there's anything wrong with the box, we're going to go up to the patient and then we're going to cut the tube that is connected to the patient. And then we're going to cut it, place the end of the tube in sterile water, and then we unclamp the tube and call the doctor. Remember, this has to be done in less than 15 seconds. However, if the tube becomes unhooked from the patient, first thing we do is we cover that wound with a gloved hand, and then we're going to take a piece of sterile gauze with Vaseline. Some people call it a PJ gauze, petroleum jelly gauze. You're going to take a piece of sterile gauze with Vaseline, and we're going to tape it down on 3 out of the 4 sides of the square. This is going to be able to help with chest wall expansion, lung expansion, etc. When it is finally time to remove a chest tube from a patient, make sure we place them in semi-Fowlers. This will be a sterile procedure. We're going to instruct the patient to take a nice deep breath in, hold it, and bear down. As they're doing that, we're going to remove the tube. Then we're going to cover it with sterile petroleum jelly gauze. A couple different reasons a patient could have a chest tube. They have a hemothorax, it's going to drain blood. Therefore, we don't want any bubbling in the collection chamber. However, if they have a chest tube in for a pneumothorax, we're removing air. Therefore, bubbling will occur in the collection chamber. And then finally, we have a pneumohemothorax. This removes blood and air. Up next is ventilators. Really, it's just important to understand what we are hearing and what that might mean so we can provide an appropriate intervention. So we've got our low pressure alarm versus high pressure alarm. Think hold. If you hear the high pressure alarm, think obstruction. If you hear the low pressure alarm, think disconnection. So with that low pressure alarm, this is triggered by decreased resistance to airflow. Think it's been disconnected from the patient. If we hear that high pressure alarm, this is triggered by some sort of obstruction. So the patient might be bucking the vent. They might be kind of clamping down on the vent. They might need a little bit more sedation. The tubing might be kinked. Always check your tubing for kinks first. Or if there is a mucus plug. Therefore, we are going to suction as needed. After a patient has been placed on a ventilator, we're going to want to check what number is at their lips and teeth so we can make sure that it stays where it's been. So let's say they have the vent in and you see a marker with 36. We're going to want to chart that every time we assess the patient. Is it at 36? Is it still at 36? You go in a patient's room and you see that it's at like 48. We're going to need to call the doc because it's came out of place. We always suction as needed. And last but not least, we have some common skills and procedures. We've already discussed administering medications through feeding tubes. So you have to make sure that it is the appropriate medication, that we give them one by one and flush in between. When irrigating a wound, we always want to focus on pain management first, and then we irrigate with a needle and a syringe, and we flush continuously. Shoulder slings are a big topic. Just make sure that the hand is above the elbow at a nice 90-degree angle, and we want to see their hand. We want to see the palm and the fingers coming out of that sling. Okay, we don't want the sling to be supporting like the wrist and the fingers. We want it to be supporting the wrist, but the fingers need to be visible. If they're not, it's putting a lot of pressure on those fingers and it's not properly supporting what it needs to support. If we ever need to culture a wound, flush the wound with normal saline first. That way you can get a nice fresh culture. We always swab from the middle of the wound to the outside of the wound. When getting a sputum sample, make sure we get it first thing in the morning. That's when it's best. And to get it, have the patient sit up, inhale, and cough. When we're talking about triple lumen catheters, it's very important that we reposition and we flush. When removing a triple lumen PICC line, make sure the patient is high up in a supine position. And as you remove it, they need to bear down and exhale. We're going to cover with an air occlusive jelly. This is because these triple lumens lead directly into the heart. When dealing with a patient who requires hearing aids, we always make sure that they are at 0 volume before we put them in. And once they are in, then we turn them up as needed. This is going to help avoid eardrum damage. When caring for a patient with trach, when we are replacing the dressing, we're going to use clean gloves to remove the old dressing. After the old dressing is off, then we can put our sterile gloves on. This is because that dressing is old, that dressing is soiled, that dressing is not sterile. So we should be using clean gloves to remove the old gunky dressing. And then when it's time to put on the new sterile dressing, we're going to put on our sterile gloves. We're also going to use a sterile kit to clean. We keep the old ties on until it's time to put the new ties on. When it's time to put the new ties on, we make sure that we put the new ties on and then we remove the old ties. When suctioning a trach, we suction for 5 to 10 seconds and we must wait 1 minute in between suctioning. This is because the patient cannot breathe while we are suctioning. We always suction as needed. Okay, tell them to keep coughing. When giving an enema, if a patient is experiencing pain, pause the enema and we're going to lower it. They work by gravity. So usually we start with it high up, but if they're having a hard time tolerating it, just slightly lower it. Okay, Sims position is best. When changing a dressing on a PICC line, this will be a sterile procedure. So make sure the patient holds their breath and turns away. Also place a surgical mask on the patient. Whenever administering IV potassium, it must be ran through a manual pump and it cannot be ran quicker than 10 mLs an hour. If the patient has a central line, then we can do 40, but it must be on a manual pump, meaning a pump that can be programmed. It cannot be ran through gravity. When your patient is getting a liver biopsy, we always assess our heart rate and our respiratory rate as well as PT-INR. Biggest risk in liver biopsies is bleed. So therefore, if they had the biopsy on the left side, we're going to have them lay on that site for 2 to 4 hours after procedures. It's going to help apply pressure. When getting the biopsy, have them hold their breath. If we suspect that there's an air embolus in the central line, first thing we want to do is clamp the tubing and place the patient in Trendelenburg. So we're going to tip them back. We're going to provide oxygen and then call the provider. For the NCLEX, we are never going to leave our patient alone to go call the provider. We're going to stay with the patient. We're going to provide appropriate interventions. And then the last thing we're going to do is call and notify the provider. When a patient is getting a thoracentesis, this can be done at bedside. Keep them sitting upright and hunched over. What I like to do with my patients who are getting a thoracentesis is I like to sit them on the edge of the bed. I like to place their tray table in front of them so they can kind of hunch over and lean on the tray table. But it's very important that they're upright and hunched. We always flush our central venous catheters with 10 mLs of normal saline. And that is all I have for you guys. Thank you so much for listening and watching along to our fundamentals nursing crash course. I hope it was helpful. And if you guys need anything, just let me know.